Well, thank you, Brandon. I think both the Academies should give you an award for the work that you do, playing well with others. I want to echo everyone's thanks to the Roundtable, to Shaw and the staff here for hosting us so graciously, to Alina and her wonderful team who's put this together, and particularly to the Roundtable for having the bravery to go into this space, this intersection of faith and health. I'm going to talk a little bit about the Memphis Model. Many of you have heard this story before, but I'm mostly delighted today that I'm going to be able to present with my colleague, Joy Crawford-Sharp. And I'm going to tell the story of Memphis up until about the end of 2013, which is when I went and moved to Wake Forest, where I now work in public health. And then she's going to pick up the story from there. So we're going to tag team it today. And I should also say it's wonderful to be back on stage with Heidi. She has been a key leader in our Stakeholder Health Learning Collaborative, hospitals that work with most vulnerable populations. So thanks for having me. I'm going to start not with an amen, hopefully we'll end with that, but I'm going to start with the principles, the guiding principles that we think really drove the work and the success in Memphis, and that we've used to try to adapt the work in North Carolina. We call the work locally Faith Health NC, the statewide work we call NC Way, and these principles, you've heard some of these from other people before. They're nothing new really, but I think it's good to put it all in kind of one slide and go through it quickly. So I'm going to name some of these, and then I'm also going to thread them into the story of Memphis. So some of the guiding principles we start with assets, okay? You've heard a lot of that from many other speakers today before, but we're really not focused on deficits. You really cannot build a community based on what you do not have. Our theory is really built on that African Religious Health Asset Program that Gary keyed up this morning, early in the morning, and talked about a little bit. And for those of you that missed that, it's really key to making the assets that are already available, that are already out in the community, visible, aligning them, leveraging them, mobilizing them in flat partnerships. Partnerships where there's not a power differential. And sometimes that's very difficult to do in community and congregations versus hospitals, right? Because they're usually the gorilla in the room that owns the assets and that sort of thing. We look at community scale. Again, we're not looking at just the provider-patient dyad when we're looking at work in terms of the intersection of faith and health, but we want to build at community scale. We want to build for sustainability and for the long run. And we also want to build by building capacity in the people in the community that we partner with. That's really, really critical and was really critical to the educational process in Memphis and what we're also doing at Wake Forest now. Trust building, you've heard that word many, many times before, but I think that if we had to pick one thing that's most important, it's building trust, or maybe even repairing trust first, building trust, and then nurturing and holding that trust, which is much harder to do than one might think. Humble leadership. I think this is really, really critical that your leaders in each of the camps or many of the stakeholder camps have to be people that have a humble spirit. And from the health system side, it needs to be health leadership that really, truly believes in community intelligence and doesn't just give lip service to that. You hear that sometimes from CEOs. Community-based participatory research principles, many of you know that. I wish the gentleman that was in the back earlier, the clergy, was still here because that really entails bringing people and partners to the table at the beginning, to co-create from the beginning, to share risks, to share benefits, to be transparent in how you design a program or do the work. And as Joy will also talk about that a little bit more, but we really co-created and we really, everything we did in Memphis was really designed to be a co-creation product with our clergy and our community partners along with our staff in the health system. We are person-centric, not hospital-centric, or not even patient-centered care, right? Hospitals patted themselves on the back when they started talking about patient-centered care. Well, we think that the person's journey of health, of course, we know most of health outcomes are really predicated based on things that happen outside the doctor's office or the hospital. So where you work, live, work, play, worship, etc., really has a lot more to do with what your health outcomes are. So we think about that a lot. And we think about following that journey instead of just whenever you touch the hospital system. Ours is an integrative strategy, which is integrating traditional clinical or biomedical care inside the hospital with community caregiving outside the walls of the hospital. And that's really, really important, I think, in terms of the work we did in Memphis and what we're trying to build in North Carolina. We often said that the hospital is the disease management entity and the health system is the disease management entity and the community is the health care entity. I think that's a really good point. And then lastly, and this is sort of the work that I kind of went into the space in Memphis as well as Wake Forest, you really need some sort of shared data protocol that has indicators that are valuable to all the stakeholders. And they all speak different languages, and they all value different things. So that's really important. We do a lot of qualitative and quantitative mixed methods of designs. We're pulling in data from different things, ranging from community participatory processes and mapping to community caregiving process metrics to quantitative metrics that we take from the hospital. So I think those are really important principles. So let's start with assets, and I'll give you a little of the context of Memphis very quickly. Many of you know the story of Memphis, but we often think of it in terms of the assets on the ground as the city of four kings. The blues is a huge asset in Memphis. Of course, it came out of lament of people that lived in poverty and struggled. B.B. King, it was the blues man who died a few years ago. He was one of the few blues men that actually died at a ripe old age instead of being poisoned or shot by a jealous lover, that sort of thing, right? Elvis the King was the second king, and many of you have visited Graceland. I think it's one of the top 5 tourist attractions in the country. But the most important king in Memphis is Christ the King. It's a very Christian community. About 85% of the congregations are Christian. I'm sorry. I moved on. Oops. There we go. There we go. And then the last king of Memphis, unfortunately, is not an asset, but really a liability and a historical trauma. That Dr. King was assassinated on our ground in 1968. So this next April the 4th will be 50 years that assassination occurred. I think Memphis is very much a city that almost has post-traumatic stress disorder secondary to that. We have a lot of racism, a lot of elitism. There's a ton of disparity, unfortunately. You know all these statistics, but I'll hit a few top ones. African American families make about half the median income of white families. Heart disease is twice that. Cardiovascular disease is twice that in blacks than it is in whites. We are the amputation capital of the Southeast due to unmanaged diabetes. Many of you saw the Whitman article that came out in 2012 in Cancer Epidemiology that of top largest 25 cities, the incidence of breast cancer mortality in our African American sisters is the highest across the country. And we worked on that with an Avon and Komen grant. But we've got a lot of problems in this city. The story of CHN actually starts with about 2004. The gentleman on your left is T. O'Neill Crivens. He's a big, beautiful teddy bear of a Baptist pastor in one of the toughest parts of town that Joy will be talking about in a minute, 38109, south part of Memphis. He was pastoring the then CEO of Methodist South. There's 7 hospitals in the Methodist system, but Methodist South was located in the most egregious area of disparity in the city. And this is Joe Webb. Joe Webb went to church at Crivens Church, and they started a health ministry of he and about 11 other clergy started this. They had quarterly breakfasts, they trained some health ministers, etc. But that was the seed of what became the Congregational Health Network. Joe had actually read the IOM report on unequal treatment, and he noticed that the fastest growing businesses in Methodist South area were dialysis clinics. And so he said, we've got to do something. The next part of the story you all know, and this is actually Gary when he had a little darker hair, actually, back in 2005, I think it was. But you'll see this embodies the humble leadership that we talked about. The guy on the left is Gary Shorb. He is the CEO of the whole system of Methodist, and he really embodies humble leadership, really cares about people, very compassionate person, always wanted to do the right thing. But he did something different. Instead of hiring a chaplain or someone traditional, he hired Gary Gunderson to come to town and actually bring in his background at the Interfaith Health Program at the Carter Center in Emory, and then the African Religious Health Asset, what we call our Happy in Eyes. So Gary came to town, saw that he didn't know much about Memphis. We began a mapping process to really look at what was going on there. The next part of the story is that when Gary Gunderson looked around, he saw one of the great assets of Memphis was Bobby Baker. now Reverend Dr. Bobby Baker, was a contractor, then became a bivocational Baptist pastor at Magnolia Baptist Church, but he was the chaplain at Methodist South Hospital. Turns out he's quite the systems thinker and a brilliant fella, and is now still Director of Faith and Community Partnerships. The CHN, I think, he is really the spiritual, emotional, and intellectual leadership of the Congregational Health Network. But the other thing that Gary Gunderson did with the leadership at Methodist was that he was able to spark their imagination to see that communities and congregations were not just sort of a liability, keep these poor people out of my emergency room, but rather assets, right? These are people that we can partner with, that we can all build capacity and work together for the greater good. And he actually convicted the board to take on, in a really tough town like Memphis, the idea of building, improving the health status and improving health access for all. And that was a really big order for Memphis. So this is the structure slide many of you have seen before. And really quickly, I'll just give you a quick rundown of what this has grown to. Bobby was the director. The navigators worked inside and outside of the hospital, signed people up into the network. We signed people up via covenants, and it took us about 9 months working with 25 pastors to co-create that covenant, what Methodists would do, what the pastors would do. We trained liaisons. That was one of the parts of the things that the clergy agreed to. These are like health ministers, and they were the unpaid staff that really drove the outcomes that you'll see in a minute in the other slides. And then you'll see over here on the right, we have now signed up and actually preloaded in the electronic medical record over 20,000 people. But you'll see the little green folks that are up there. Well, you know, those are the people that are ill. When they come and touch our system, that's when they come through our system. And the data that you're going to see is really an inpatient kind of focus. So one of the good things that was happening about the time CHN was being built out was that Cerner, our electronic medical record vendor, was interested in this and helped us build out a navigation pane. This is a screenshot of the navigation shot that would come up when persons would come into the hospital. Admissions would say, "Are you a CHN member?" Yes. Do you agree to opt in to allow your congregation to know that you're here in the hospital? If they said yes, they would hit a drop down of their congregation, click it, and they would be loaded to flag a navigator to come and visit that person. But what it essentially did was alert the congregation, the clergy, and those teams of liaisons, those unpaid staff, to help visit the person inside when they're in the hospital, and more importantly, to plan for discharge when they left. So you have a virtual team that's working on this all the time. So quickly, I'll share some of the outcomes, but one of the things that's really critical, and we've talked about this before, we talked about that shared data protocol. It's really important, I think, to say that CHN was really built to improve the health of everybody. It was not built to be a research protocol. And so some of the data that I'll show you, we know we kind of poke holes in it in terms of validity, reliability, et cetera, but it was really not driven by a research protocol. But our working hypothesis in terms of the data you're about to see is that the Congregational Health Network folks received standard clinical care, and everyone that came through Methodist received that, but the CHN folks got that along with that community caregiving. And we published a paper in Population Health Management in 2014 that talks about the difficulties of building, measuring, doing all this work all at one time. So what I'm about to show you are just some quick data points from a cross-sectional snapshot when CHN was 25 months old. We compared people that were controls that had come through the hospital at the same time, just inpatient care, to CHN members that had come through at the same time, and they were matched on age, gender, and DRGs. So quickly, we thought length of stay would be very different. It was not, right? But readmits were quite different, and CHN was improved compared to the non-CHN members. Mortality rate was about half. That's gross mortality rate. And quite frankly, that data has held up very consistently over time. And I can tell you, one of the most fun I ever had was going with Bobby to one of the Baptist Ministerial Associations and saying to the pastors in a church about this size, you know, the work that you're doing is saving lives. Look at this data, right? Instead of gross mortality rates, it's, you know, the work you are doing is protecting lives. You know that you do that, but it was really neat to provide that data for them. What really has always impacted people was looking at the charges. These were gross charges. But for the CHN, it was about $4 million less than that early cohort. And the N was about 500 people. It was 473 people. And unto your right is a per capita measure of that. Just looking at the different conditions where it was matched on DRGs. Look at the difference between CHN on the left and non-CHN on the right. Particularly look at diabetes. So these were really sort of the early adopters of the work, and Bobby's congregation was one of the key ones, but I think it drove a lot of these really good data and differences that we see. And then that was what you saw was a between subject design. We took some of those 473 people that had been through the system before CHN was activated and after. So basically we were looking at Mr. X before they got the care with CHN and how many hospitalizations or utilizations they had and how many charges compared to after. And in yellow, you will see the indicators here that were significantly different. Admits per patient, readmits, days, and then average charge per patient, quite significantly different. But we know we needed more rigor, and so we reached out to a team at Indiana University, led by Priscilla Barnes, who's still there, and we did Cox's predictive modeling for 3 years before CHN and 3 years of CHN functioning. And we looked at many, many records. And if you look there down on the left, you'll see the matching variables that we did some pretty rigorous matching of the non-CHN versus CHN. And what we found was that for all diagnoses, all APR-DRGs, people inside CHN were staying out of the hospital about 70 days longer. So the median time to readmission was 70 days longer. And this is pretty significant because our population actually, our number one diagnosis was congestive heart failure. And you just manage that, right? You don't cure that for sure. And we had significantly more people over the age of 65. This is church, right? So these were older people. So that was pretty impressive data. And then just here's some quick annualized data on that mortality rate. Again, look at that odds ratio. CHN folks had that lower gross mortality rate. Navigation to home health was significantly higher. This is annualized data presentation. And then the data point that impresses me the most, I'm proudest of, because this is a majority African-American town. There's a lot of distrust of health systems, and we were able to navigate more people to hospice in CHN than the total population of Methodists. Pretty impressive. So in 2010, ACA was passed, and we turned our thoughts to hotspotting. We had met Jeff Brenner and heard about his work at Camden, and we began doing our geocoding and work. And Memphis is what we call a land of comorbidity cocktails. Most people have 4 or 5 different chronic conditions, and we began looking, of course, at the hot spots and hot zip codes. And Joy is going to tell you all about 38109 in just a moment. But we found that top 10 zip codes accounted for over 50% of our whole system charity care, but for inpatient, 38109, the zip code that we'll go into in just a moment in terms of our place-based work, represented almost 65% of that total charity care. So there were a lot of folks that were coming from that area that had uncompensated care and big needs. And this is just a visual of some of those charity care folks. Somebody mentioned this before, you could almost throw a rock and hit every house in certain blocks in hot neighborhoods where that charity care, those folks were residing that needed that charity care. So I'm about to hand things over to Joy, but you'll see again, there's that humble leader, Gary Shorb. Gary Shorb heard about the geocoding that we had done, looked at the hot spotting, and we decided we'd go participatory. We wrote a little descriptive paper about this. Chris Bounds, who worked with Bobby Baker and had grown up in 38109, took Gary Shorb on a tour. And that's James Kendrick there in the purple shirt. He has a health ministry called Health Watch in Riverview, Kansas, where Joy worked predominantly. A really tough neighborhood. She'll tell you more in a moment. But it really started the process. And then Gary Shorb brought the leadership group back to tour the area. And I'll never forget Reverend Eric Winston, who's one of our key leaders in CHN, was laughing at the podium, and he goes, I don't think I've ever seen this many white people in a room that weren't buying drugs in a very long time. And everybody got a good laugh about that. But because of our efforts, Cigna executives, that's one of our big payers in Memphis, had heard about our efforts. And so we had begun to do focus groups on the streets. Because of Kendrick's trust by proxy with me, I was able to do the most amazing focus group I've ever done, where I stood in a burnt-out apartment area on Riverview, Kansas, which Joy will tell you about, and 12 young men of color stood around me with Kendricks, and we did our focus group. And they wanted all the same things everyone wanted. They wanted health care for themselves and their children. They wanted access to dentistry. They wanted health care access that treated them with respect. That was really critical. But because of that work, Cigna gave us a fairly large community grant, which enabled us to hire our first place-based navigator, Joy Crawford Sharp. And she really had that person-centered approach with the wellness without walls, the hospital going out into community instead of waiting till people became those patients that used up charity care. And she's going to tell you about that in a second. One last data set slide. We had seen a gross net percent of change in terms of charges in the years before we got to ground in 2011. I think charity care overall in 38109 had gone up about 38% the year before. The year we got on the ground, it dropped 8.9% for 38109 and 6.9% for all patients. But Chris McLean, who was our CFO, said, we need a more rigorous measure. And so he asked us to look at and create with the business group that we worked with there at Methodist Le Bonheur, what he called the cost-to-charge ratio. So instead of looking at just charges, looked at the cost of the transactions and then did a ratio there. And you can see that those numbers were dropping into the point that I left town there at the bottom, or stabilizing when I left. So I'm going to now turn things over to Joy.
I promise I have more clothes.